We'll be continuing with our blood culture case discussion. First case, we have a 25-year-old male with complaints of recurrent blisters developing spontaneously or following trivial trauma. It's been there since birth. The blisters rupture within 1 to 2 days, leaving behind raw areas that heal with discoloration. Associated with itching and burning is history of topical antibiotics and steroid use. But what antibiotic, what steroid, not mentioned. So this is diagnosed to be a case of epidermolysis bullosa, biopsy proven. The patient also shows erosions with diffuse yellowish white crusting and scaling. So this is the patient. You are able to see yellowish white crusting, especially the elbows and knees. And on examination of the scraping, you are able to see sarcoptes scabies. This is a form of crusted scabies. So the boy's other sibling also has a similar situation. So they are suspecting some genetic cause behind it. So this patient, his latest CBC, you are able to see that the total leukocyte count is elevated, 17,500. You are also able to see that his procalcitonin over the last 2 days, it is again elevated from 39 to 94. Other tests are negative and non-reactive. I have specifically put up the iron profile for this patient because this is a chronic disease. And in this case, you are able to see the patient having a mixture of anemia of chronic disease and an iron deficiency component also. So here you are able to see serum iron levels are less, whereas the TIBC levels are also less, whereas the ferritin levels, the storage form, is increasingly high. So as we said, so there is dimorphic anemia of the peripheral smear with neutrophilic leukocytosis. So there is some sort of neutrophil expansion there. The retic count here is 3.5. Corrected retic count comes around 2.1. You are also able to see that the LDH is grossly elevated. This can say that there is hemolysis, or this can even say that there can be an underlying malignant process which is happening. Bone marrow involvement can be the case. So in our blood culture, sample sent on 15th, it's a paired sample. Both the samples grew MRSA. This MRSA also happens to have an inducible clindamycin resistance component. So the BMQ in this isolate is higher for teicoplanin among the glycopeptides. So already before sending the blood culture samples, they had already started the patient on clindamycin 600 mg twice a day for 5 days. In addition to that, if you are able to see, so the patient has topical antibiotic in the form of mucorocin. For scabies, he's been receiving ivermectin. Ivermectin, they have this 7-day regimen on day 1, 2, 8, 9, 15, 22, 20. So they have this regimen according to WHO. So he's also receiving ivermectin. Topical permethrin 5% solution is receiving. And with the report, injection teicoplanin 400 mg loading dose BD given. And from the third dose onwards, 400 mg OD dosing is given. The patient has some mucocutaneous lesions also in the form of, they are suspecting it can be thrush. So they are also giving clotrimazole mouth paint in this patient. He is also receiving some probiotics. So the patient's BMI is very less. It's 11 to 12. His height is 158 centimeters and his weight is 29 kgs. So this component we have to keep in mind, because when it comes to antibiotic administration, PKPD, this cachexia plays an important role. Next one component is cachexia. Next component I have highlighted here is patient is having gross hypoalbuminemia. So the drugs which we are seeing here in this case, if they are highly plasma protein brown, what will happen? Free concentration of the drug is going to increase because it is not going to get bound to albumin. So the component of cachexia and the component of hypoalbuminemia has to be dealt properly in this case. So you are able to see the albumin globulin reversal has taken place. So summarizing, we have a 25-year-old male who is cachexic, who has hypoalbuminemia, who has MRSA bacteremia, and in addition to that, scabies is also there, and we are planning to start teicoplanin. We have already started teicoplanin and ivermectin we got. So what happens in cachexia? Important thing we have to see is there is reduced fat tissue is there. So we can't calculate our antibiotic dose calculation based on our actual body weight or even ideal body weight or total body weight. We have to do adjusted body weight calculation because here the fat mass has totally decreased and the volume of distribution as such has also decreased. So here coming for teicoplanin, teicoplanin is a glycopeptide drug. It has very high protein binding in the form of 90 to 95%, primarily to albumin. Excretion is mainly renal, volume of distribution is moderate. Here in this case, what is going to happen? Massive increase in free active drug fraction is going to happen. It is measured by the total drug levels. More important is the cachexia because of the reduced volume of distribution. As we said, actual body weight, if we use 29 kgs, we are going to underdose here. So we have to use adjusted body weight, that is the formula for that, ideal body weight plus 0.4 into actual body weight minus ideal body weight. So here actually the calculation comes up to be a loading dose of 450 mg 12th hourly instead of 400 mg. So in this case actually we have underdosed it owing to the cachexia component. But another thing in this case which you have to even more, if hypoalbuminemia wasn't there, this is a simple equation. Since hypoalbuminemia is also there, we have to, this is an ideal case to measure the TRO levels of teicoplanin. So TRO levels of teicoplanin, if we have a TDM facility, measuring the TRO levels of teicoplanin in this case will be important because only then we will know whether that therapeutic levels of teicoplanin is reached. Because in cachexia subtherapeutic levels will happen. If hypoalbuminemia is there, we will be thinking normal level of drug is there, but it can cause toxicity also. Coming to ivermectin, we may think ivermectin actually scabies if it is very mild. Usually there is a 1-dose regimen, there is a 3-dose regimen, 5 doses. But since this is very severe in this case, they have almost given 9 doses. It's usually 200 microgram per kg. This is very minute dosing only. It's also highly protein bound. Here in this case, because of hypoalbuminemia, we are going to have a huge free fraction of ivermectin. Ivermectin is known for its CNS side effects. So you have to keep watching patients having any encephalopathy features, any ataxia features. It has to be monitored. And in this case, if possible, if you are able to reduce the dose of ivermectin by half, or even instead of giving a 9-day dose, make it a 3-day regimen or 5-day regimen, it is drastically going to decrease the side effects of ivermectin on the CNS. So this is a paper which says higher serum ferritin levels is a prognostic factor for Staphylococcus aureus bacteremia. So in this case, you are able to see like they have 109 Staphylococcus aureus bacteremia. Treatment failure within 30 days, they occurred in 41 patients. So when they saw which are all the main risk factors for this treatment failure, bacteremia score, we have this bacteremia score that is more than 3, resistance to clindamycin, ferritin levels more than 500. So all these are independently, not as composite, independently associated with increased risk factor. Why I specifically put this? Because in our case, all these 3 are positive. So we follow up the patient, we have to see how the patient is improving, whether this bacteremia is getting resolved or not. So yesterday only we have told them regarding this. So echo and fundus is yet to be done. So
First. Next. Yesterday. see, inducible clindamycin resistance is positive. So ideally the report should go on as clindamycin resistance. Okay, this is a overlook on my part. And when we are entering in Pune, if you place clindamycin resistance as positive, in screen it shows as resistance. But when it comes to your it is coming as susceptible. So that part you have to look into. Next thing is, though this is inducible clindamycin resistance positive, and we should not use clindamycin as a therapeutic option, clindamycin still can be used for what?
PVL toxin.
For PVL toxin, you can use it as antitoxin. So, if it is inducible clindamycin resistance also, but if it is blood, you can still use clindamycin as an antitoxin.
You go to next case.
This was I was telling you yesterday to you. We have insisted on vancomycin rather than type. Any news on TDM facilities? No.
Very high. Ferritin is very high.
466 something.
479. Normal is more than 15-year male, 250. Almost double the high upper limit of normal. So, so it's acute phase reaction. No? The chronic inflammation is happening. Chronic breakdown of skin is there. So IL-6 will be produced. IL-6 will the mechanism, if you read, there's a molecule called hepcidin which is produced that will regulate this iron transport and all. So that will also get stimulated. And in addition, if patient has MRSA from the skin and so many barrier is broken, it will go into the blood.
They were telling you were telling that they are suspecting some malignancy also.
Yes, sir. So some myelodysplasia or hematological malignancy also it can.
In that case, the count should be too high.
Sir, it can. Now actively it is not there. They are saying, sir. He may progress to it like that. They are saying, sir. Because LDH is very high and bone marrow starting to fail, and this ferritin levels. One more thing, sir. One more thing, sir. HIV status negative, but this specifically they have done in card test, sir. So I have asked them to repeat with Clea or Eliza, sir. Only Eliza. One more, I have not put one investigation, sir. B12 is more than 2000, sir. So that can also, it can go towards like some hematological problem can be there, sir. Vitamin D is severely low, sir, because patient he doesn't.
See, when there is no skin from where the vitamin D is accumulated, isn't it? So vitamin D is not a problem. If we want to hold water also, maybe less vitamin D. We are not exposed to something.
Total IgA is also elevated in this case, sir.
See, everything said and done. They have done all the things. All the parameters have been checked. Now they don't know what to do with that parameter. Is it? So why to do all these things? Let's focus on the primary thing first. Once it is resolved, you go on doing whatever you want to do.
Next we have a 36-year-old male with severe mitral regurgitation as an has a vegetation in his posterior mitral leaflet in the size of 7 into 11. So the cause for this, they are saying patient may have mitral valve prolapse, and there are an anterior and posterior mitral regurgitation jets are also there. So the patient developed atrial fibrillation with fast ventricular rate, reverted back to normal sinus rhythm. So actually the patient prior to 24th of October, he had 5 to 7 days of claudication pain in the right lower limb. So with that he came to our hospital and they found to have acute right lower limb ischemia. So on 25th, the next day, they had done a catheter directed thrombolysis. 2 days after that, balloon mounted stenting was done in the right common iliac artery and the external iliac artery. So patient was on blood thinners. He was on blood thinners during this time. So he happened to develop a frontal lobe hemorrhage with subarachnoid hemorrhage bilaterally, and there was pneumocephalus within the ventricles. So an extraventricular drain was placed on 31st of October. The patient is a type 2 diabetes mellitus, sick with thyroid, smoker. So these are the comorbidities. And on 24th, this is on admission here, enterococcus was there. So here you are able to see the image on your left side where the block was there, and after stenting you are able to see balloon is inflated. So patient received injection ampicillin 2 gram IV 6 times a day and injection ceftriaxone 2 gram 2 times a day for 3 weeks. Followed this, he was discharged on tablet amoxicillin 500 mg 4 times a day for 2 weeks. So totally he has received antibiotics for a duration of 5 weeks. So now he is presented to us with 10 days of fever, which is low grade. Every day morning it is there with some cough and sputum production. Patient is pale. As of now, fever is not there on admission. You are able to see you are able to hear a pansystolic murmur, grade 3, which is also radiating to the axilla. So this case, can someone take a guess how many cultures they have sent? Like at least blood cultures alone. Almost 15 blood cultures they have sent. So we were discussing also first Enterococcus faecalis, the ID. Even before that, one blood culture they have sent from urology side. So patient had pyelonephritis prior to all these episodes. So these are the list of blood cultures, which blood culture is that CSF culture. They have mentioned CSF culture. But when I asked them personally, they told it was that extraventricular drain. So on 29th September, the Enterococcus faecalis was isolated. This ID we have given Enterococcus faecalis. So this was in view of pyelonephritis in the admitted under urology. Blood culture we got Enterococcus faecalis. Next, when he had this claudication episodes and when he came in October, that is when we had given again Enterococcus species was given. Then we started the double beta lactam cover was given, and the subsequent cultures came out to be negative. This here, the arrow which has come now is an important arrow because on 19th he is being discharged. So till this 19th he has received properly 3 weeks of ampicillin plus ceftriaxone. 19th he is getting discharged and he started on amoxicillin. So there is inadequate oral coverage in this case. Monotherapy you shouldn't encourage in case of endocarditis, vegetation positive endocarditis. So after this inadequate coverage, he again comes for readmission. In between there is one blood culture where some contaminants are grown, and the latest blood culture on 12/12 again we are growing Enterococcus faecalis, which has been negative the whole time. Has again seeded since the vegetation is still there in situ, it has seeded into the blood and again has come out to be positive. So if you are able to see 3, 5, 6, 13, almost 15 out of 15 blood cultures we have reported
14, 11, there is 7.
Yes, sir. So they had said that time they are planning for discharge, sir. On 13th, 14th they sent, sir. So 5 days it will come. On 19th they discharge, sir. Once all these both 13th and 14th everything came out to be negative, they will say okay, microbiological clearance we have got, and they have discharged.
Now fever spike still is there.
Sir, now fever spikes are not there, sir. But patient he has that fatigue is there, sir. Decent.
So this 29th September.
First one was 29th.
And August because what they did after that? Anything?
Sir, after that, what antibiotic they started, we don't have that details. We don't have. Sir. Whether that time they started antibiotic, we don't have the details, sir. Between September 29 and 24th, what happened, we are not aware, sir.
At that time, he was admitted.
No, sir. After that, admitted under urology, sir, 29. Then the 20 days he was discharged, sir.
Can't we get MRT from MRT? What is there? Because yesterday we were discussing, day before yesterday, that what may be the CD. This might be the CD. From the pyelonephritis it might have gone. And this 24th October, is it reported as Endocarditis species or Endocarditis species?
So species, sir, since we have already discussed it, I have kept as species, sir. Confusion there is.
That fissure is, it is vital report, isn't it? But it shows excellent identification, and both of the blood culture have grown Endocarditis special. However, in one there is your synergy negative, and in one it has given us synergy positive. So maybe to avoid more conservative approach, we might have reported as registration, we might have taken that as synergy negative. But again, where here your ampicillin and cephalosporin is being given? We in and out tell that for Endocarditis ceftriaxone and intrinsically cephalosporin is intrinsically resistant. It is endocarditis and we are giving ceftriaxone and we are recommending ceftriaxone. Anything? Different penicillin pyridine protein are in action here. Ampicillin, your which one?
In Enterococcus, we penicillin 4 and 5 importantly, and to a lesser extent 2 and 3. So 4 and 5 are more important for Enterococcus. So ampicillin will be saturating that. 2 and 3 to a lesser extent. So ceftriaxone will be just an add-on drug. Only in the presence of ampicillin, ceftriaxone will work.
PBP, it acts on PBP, no? Beta-lactams. So the ampicillin or the ampicillin amoxicillin component will act on PBP 4 and 5, which is more expressed in Enterococcus. And to lesser extent, it is expressed PBP 3. So ceftriaxone usually acts on PBP 2 and PBP 3. So that part is taken care by ceftriaxone. So though we tell that in normal conditions cephalosporin is intrinsically resistant because of chance of your getting the serum trough level to kill the bacteria is not sufficient, but in this case this is a synergy sign. And to negate the effect, because ideal treatment is with a beta-lactam and aminoglycoside if it is your synergy positive. So here we have reported synergy negative. Second thing is, if at all it is synergy positive, the duration of aminoglycoside that is to be given may have nephrotoxicity. So to negate toxicity, and it has been found that the outcome is almost similar with the beta-lactams plus aminoglycoside versus beta-lactam plus beta-lactam.
So coming to the latest CBC also, in 1212 you are able to see it's mildly elevated, almost 12,000. ESR is also mildly elevated, CRP is elevated, Procal is normal. So coming to our AST report of Enterococcus faecalis, this is the latest sample on 1212. We are able to see it's a penicillin susceptible strain, and there is also synergy for high level gentamicin. So this is the elaborate AST with the BMQs and interpretation. So point to note here, penicillin has an MIC of 8, which is the upper limit, so BMQ will be 1. Teicoplanin has the highest BMQ in this case. Apart from that, you are able to see even our ampicillin, which you have not measured by MIC rather by zone diameter, that also has come out to be susceptible.
For verification, are they planning for any intervention?
Sir, no surgery they are not planned. So they want to complete this 6 weeks. They want to complete this, and then only
once it becomes sterile, they
sterile
are
they
planning.
will.
Now patient is on MIC or cardiology?
This is cardio, sir, D5.
Sciences.
So here we have suggested teicoplanin. If it is apart from any endocarditis, teicoplanin is a very good drug. In valves, penetration of teicoplanin may not be very good. So here we are still going with the combination of ceftriaxone plus ampicillin. Gentamicin is also a very good option, which can be given along with ampicillin. So this is the treatment chart. So we have again from that optimal treatment of amoxicillin alone, we have again asked them to continue with ampicillin and ceftriaxone. So ampicillin totally per day they will be getting 12 grams. Ceftriaxone per day they will be getting 4 grams. So an important drug-drug interaction here has to be noted. Ceftriaxone, as we know, it is very well excreted in the bile. It is very well excreted in the bile, right? So it again goes to your gut. It is excreted. So similarly, so it will go and affect a lot of it will kill your gut flora. Ceftriaxone, since it is again excreted through your biliary tract. What does warfarin do? Because this patient is a case of he's had the thrombosis and all, no? Claudication. So they still kept him on warfarin. Warfarin inhibits the enzyme for vitamin K production. The vitamin K antagonist. So this vitamin K is produced by all these good bacteria in the gut. So these together will cause lesser production of vitamin K dependent clotting factors. So again, risk for it enhances warfarin's effect. There can be risk for hemorrhage, so we have to be careful with that. So we have to monitor your PT-INR values. So far this case it is normal, but this at least once in 3 days.
But INR is quite low now.
So normal is 0.8 to 1.2.
In case of your if there is thrombus formation, the target is to keep it
At the lower, higher limit.
1.5 or 2.
Now it is 0.3.
So whether that is one thing is that one, and second is whether to give warfarin or direct your
10 inhibitors.
yeah,
Apixaban.
because they will not have any effect on your
Vitamin K.
vitamin K also, and
2, 7, 9, 10.
and when that subarachnoid hemorrhage occurred, what is the PT-INR at that time?
Take note.
It is either the result is not correct or is underdosing, what I feel, for warfarin per se. chance of clot formation will be there.
This we can give as rationale to switch to gentamicin also, sir, if the INR worsens, sir. Ampicillin plus genta combination can be.
But at that time again you have to check the kidney functions.
Kidney function so far is good. Pathogens will finish first. This is a scoring system called de novo scoring system with respect to enterococcal sepsis and endocarditis. Initially it was called NOVA scoring system. Now they added two more components to de novo. It's a 2019 paper, important paper. So among 397 people, MEEF is monomicrobial enterococcus fecalis bacteremia. So 44 episodes of IE were compared to those without IE. So in this, so each D, no, DE and no 6 points. No? So in this, if we have more than equal to score of 3, it says sensitivity is 100% and specificity is 83%. Compared to plain NOVA, which has a specificity only of 29%. The importance of this scoring system is in this point. So in all patients, we will not be able to do trans-esophageal echocardiography. So difficult procedure, fitness, accessibility, lot of problems will be there. So in this case, if we have a de novo score of more than equal to 3, so it says patient, the likelihood of the patient having endocarditis vegetation, it is more likely. So this is the scoring system. It stands for its first letter. Duration of symptoms more than 7 days. Our patient had more than 7 days. Embolization. So that would have been the possible source. So it is there. Number of positive blood cultures, we saw how much 4 blood cultures were positive. Origin of infection unknown. So this valve from, it is there in the leaflet, but to come to the leaflet from where it came, as sir showed, that pyelonephritic foci could have been, so again it is unknown origin for us now. Valve disease is there, mitral regurgitation, mitral valve prolapse is there. Auscultation, pansystole. So in this case, 6 out of 6 we have. This case 6 out of 6 we have a de novo score. So this is another paper 2025 recently released. MEFIR score, machine learning derived enterococcus fecalis infective endocarditis score. Around 2535 E. fecalis bacteria episodes were analyzed between a 10-year period of 2009 to 2019. So the inclusion criteria was people more than 18 years of age with at least one blood culture positive for enterococcus fecalis. So out of those around 2,500, 86 people came out to be positive for infectious endocarditis. So 4%. So this has a scoring system different from de novo, where so many different points are taken. So you have age, you have gender, comorbidities, community acquired or nosocomial, abnormal lab parameters, and a score above 32 tells us patient is more likely to have high risk of infective endocarditis. This MEFIR score. This I will just fastly go through. This is a article we got of interest because we were talking about penicillin binding proteins. And if you remember, our isolate had an MIC of, for penicillin, it had an MIC of 8 microgram per ml, right? So are all enterococcus fecalis isolates same? No. So there are several strains which are different in the same enterococcus fecalis. These two which you are able to see towards the left hand side are the isolates with less MIC. Both are susceptible, but left side is less MIC, right side is more MIC. So the MIC of 8 which we had is more likely the penicillin MIC elevated in our case. So what they are saying is, with these elevated MICs, sometimes the synergy may not work. So they have done a lot of time kill assays. They have played with the PBV4. They have induced mutations. They are seeing whether it is working or not. What amino acid addition, deletion is there. And if the MICs are elevated, your penicillin MICs are elevated, your double beta lactam synergy may or it may not work. More towards may not. So that is also, so when you are trying that, you can add a carbapenem to your ceftriaxone instead of ampicillin, that can work. If aminoglycoside toxicity, if you still consider, you can go for 5th generation cephalosporin in this case. No, if there is very high, the MAC is also high, MBC is also high, then go for non-beta lactam options like linezolid and daptomycin. So this is what we have discussed till now with respect to this case. So as much as possible, when you are reporting enterococcus, you shouldn't report penicillin alone or ampicillin alone. Both penicillin and ampicillin, if preferably if MICs are there, can be reported. And there is another strain of Enterococcus faecalis, which is penicillin resistant ampicillin susceptible, called PRASF strain. So that also you have to be careful. So that's why penicillin and ampicillin should always be reported in Enterococcus faecalis. Next case. So here we have a 69-year-old male who is a known case of type 2 diabetes mellitus, systemic hypertension and Parkinson's disease. He had a left vesicoureteric junction calculus for which ureteroscopic lithotripsy was done and bilateral DJ stent was introduced. This was on 2nd of August this year. This is because the patient was already diagnosed to have CA rectum, adenocarcinoma of rectum was there. So 1 week prior to this, since that calculus was there, they had just done lithotripsy and inserted a DJ stent. So on 8th of August, they have done abdominoperineal resection for this case. During the procedure, there was iatrogenic trauma to the ureter. So in view of that, they have placed on the left side, a percutaneous nephrostomy is also placed. So 2-3 days after the PCM, they felt it was blocked, so they reinserted it, and with that the patient was discharged. So this was on 24th of October. So then what is happening? Then the patient feels that the percutaneous nephrostomy tube is not properly, it is being pulled up. Patient starts developing fever spikes, there is elevation of serum creatinine. On ultrasound we are able to see a small collection foci of pyelonephritis. Patient is started on Puttas IV 4.5 gram over 3 hours TDS. So in this case, on December 1st we have isolated Serratia marcescens. Then in December 11th, 12th time 7th to 12th, that time we have isolated Pseudomonas aeruginosa. Patient is not having any fever spikes. And again, so this is the patient where HBV serology has come out to be positive. HBsAg is positive and corresponding antibodies are reactive. This patient also, sir, initially
detectable viral load also
26, sir. Less, sir, but detectable. So this case, sir, initially they had done lateral flow assay, sir. In that it had come out to be negative. Then after coming here, they had done this patient chlamydia. So this patient came out negative, and this also came out, viral load also, real-time PCR came out to be positive. So this is the first isolate on December 1st, Serratia marcescens. So this is our report. It's an ESBL plus AMC producer. But they are not treated for this patient. During his course, he has received only ceftriaxone and tazobactam. So if you see your our chart, we have this biomenu chart. One line will come under Serratia and the notes. All Serratia marcescens isolates are they induce AAC 6' enzyme. Except 2 aminoglycosides, streptomycin and gentamicin. Apart from that, against all aminoglycosides, it will have this adenyl acetyl transferase enzyme 6', which is going to inactivate it. So you have to be careful when you are treating with aminoglycosides for Serratia marcescens. Then we had this Pseudomonas aeruginosa. Pseudomonas aeruginosa, again on 9th we have received. It is a pan-susceptible strain. Again, by the same patient was receiving President tazobactam. So here you are able to see the blood cultures. the TLC count is mildly elevated. Creatinine is also mildly elevated. This is all because of the pyelonephritis foci. So after this, I have prepared 15 slides. Everything has gone. I will orally tell all those cases. We have a case, Valepo Anjaneyulu, who is from urology ward. For him, 2 samples of Escherichia coli in both the blood cultures were isolated. The patient had urinary retention, for which he was catheterized with 4 days. Even after catheterization, he felt that there was some bloating there. So in view of that, they had kept him in observation in our hospital only. He had 5 days of distended abdominal pain with distended abdomen, fever was there, dysuria was there. So temperature also increased. Bowel sounds were also, they were not able to hear proper bowel sounds on auscultation. So they suspected paralytic ileus along with pyelonephritis. Since here we don't have an MG consultant, they wanted to go to NRI and get a medical gastroenterology because of sluggish bowel movements. So they went on AMA. And today morning we saw the E. coli Vitek report. It has come out to be ESBL CTXM type, but peptaz and amoxiclav are also resistant. So that isolate, I think some contamination may be there. Colistin came resistant.
You need to check that.
So this since it has a 4K, ideally, but all carbapenems are susceptible to case, it is better to escalate to meropenem, 1 gram or 2 gram TDS. Now in this
case, I think it will be 1 gram.
1 gram.
Creatinine is elevated, no? 2.4 is something.
Yes, sir. And another thing is, this patient was discharged on cefodoxime. So that has to, I have told them yesterday, I informed them, so that they have to, or they are discharged on cefodoxime. So this is our 4th case. 5th case, 6th case, 7th case, 8th case, 9th case. 5 cases of cons we have. 3 Staphylococcus hemolyticus, 1 Staphylococcus epidermidis, and 1 Staphylococcus hominis. So we'll see the Staphylococcus hemolyticus cases first. One is Talpuri Manogana Sai. She is a stage 5 CKD. She has sent one sample only was sent, and 1 sample Staphylococcus hemolyticus has grown. She has undergone renal transplant also. She is only 22 years old, but still she has undergone renal transplant. After that, she developed hyperoxaluria. Because of due to that, they had resumed hemodialysis again. So during hemodialysis, they have sent 1 blood culture. And in this, we have grown Staphylococcus hemolyticus. Counts are normal. Patient is also doesn't have any signs and symptoms of infection. Coming to our next case, we have a patient Staphylococcus hominis organism. Patient Moksha Rani. This Moksha Rani is having fever for the last 1 week associated with chills and dry gut. Patient has right inguinal lymphadenopathy. In addition to that, patient has headache. Patient's DEGI NS1 negative, IgM non-reactive. Patient's Vidal is faintly reactive. The WBC count is also on the lower side, 4,000 around, and patient is already on cefixime 200 mg BD. Other evaluation for acute febrile illness, everything is unremarkable. Malaria, scrub typhus, leptospirosis, everything is unremarkable so far.
What is the fever?
Sir, they are not documented. Sir. OPD case, sir. They are not documented, but for 1 week, every day she's had fever. Sir.
Is the feeling of fever or recordable fever?
Sir, it is not documented. Sir.
Right inguinal lymph node is there. Then there may be chances of somewhere the pathology is inherited, isn't it? Female. So chance of your vaginitis and other things might also be there. For that also they might be feeling and that fever maybe for that also. Here we can overlook this concept.
Coming to our next case. we have a 60-year-old female, 64-year-old female from whom Staphylococcus hemolyticus again has grown. She is a case of complete heart block. For 1 year she's had diabetes mellitus, hypertension, mitral regurgitation is there. She had shortness of breath and dry cough. Shortness of breath she's been complaining for 1 year throughout, sir, but like acute exacerbation she got. On HRCT there was ground glass opacity, sir. Here inside they have given azithromycin and cefodoxime, sir. And patient is discharged, sir. Patient's blood
failure also.
Yes, sir.
Pulmonary
Like cardiac asthma.
cardiac asthma.
Sir, and this counts mildly elevated, sir, 14,000.
That also may be
Part of
part of that one.
So this is. Then we have so then on staph epidermidis, sir.
Both
The staph epidermidis from both the bottle staph epidermidis, sir. This patient diabetes, hypertension, TLC count is within normal range, sir. No other comorbidities I am able to recollect, sir. I'll find.
Yeah, just find out
I'll find
why he primarily ended up here, whether it is fever or something else. And if it is something else, then we may ignore it. And if it is primarily due to fever, then we have to check for the code.
Because both the bottles, yes, sir. Sir, the final case, sir. This is the Staphylococcus epidermidis case, sir. The final case what you explained was a 2x2. It's a case of orthopedic case, sir. Some trauma has happened or some fracture has happened, sir. What I'm not aware, sir. Counts are 20,000, sir. 26,000, sir. Neutrophils 90.
That may be due to trauma.
19. No.
If it is not particularly primary admission is not because of fever and we are getting such type of thing, then we should ignore it for daily. Thank you for presenting and thank you for attending everyone.